first of all, just thank you, Cherie and Kathy, for putting this on, and your group. It's really a big effort to do something like this, and it's great that you're videotaping it and recording it, I should say. And so a change of pace from genetics and tests. This is really a survivorship issue. What happens after breast cancer treatment? And I know some of your viewers may have lymphedema or have had it, or know somebody who's had lymphedema. And these are my disclosures, and I'll talk a little bit about my books later. But really, what is lymphedema? Our lymphatic system is the third sort of fluid system in our body. We've got the heart pumping into our arteries, and that feeds our cells with oxygenated blood, and then the deoxygenated blood goes into the veins. But in this area where the tiny little capillaries feed our cells and our bones and our nerves, we've got this third system, which is really almost a waste system, where it collects byproducts and proteins and all sorts of even infection and cancer, and takes it up into these lymph nodes. And we've got thousands of lymph nodes in our body. The lymph nodes are like the drain in a sink. It captures any dirt or debris, cleans up the fluid, the lymphatic fluid, and the lymphatic fluid then goes back into our bloodstream. So that's how it works. But after cancer surgery, you can have disruption of that when people's lymph nodes are taken out or irradiated. And this lymphatic system doesn't have normal valves. It's got these little tiny microfilament flaps, and muscle movement and massage can push that lymphatic fluid along, and I'll show you that later. This is I've got a couple of men on treatment at the moment. This man's having quite a tough time. He's had a left-sided mastectomy that you can see. He had a lot of complications with his taxane chemotherapy, had a lot of nail changes and skin changes. His left arm blew up even before radiation therapy, and you can see his back of his hands a bit swollen. And even his right foot became edematous, and I wasn't really sure how that happened, but I suspect it was a complication of the chemotherapy. So lymphedema is a survivorship issue. It's distressing for men and women who've had breast cancer that you can hide a mastectomy, but you can't hide an arm. And you may have people coming up to you in the supermarket and saying, "What's wrong with your arm?" And it can be quite depressing, and has this huge impact, physical, perhaps not even able to lift things or put on a shirt, for example. It can have an economic impact, the costs of garments and seeing therapists and doctors, of course, psychological impact and functional. So this is quite distressing. And then there's a study we did at the Alert Lymphedema program using the Breast Cancer Network Australia, 152 patients. And we looked at all these domains: work, family, social, self-image, feeling about self. And every single domain, it was worse. There was more distress in someone who had the double whammy of breast cancer and lymphedema. So what are the risk factors for lymphedema? The most important risk factor is the extent of surgery and whether a lymph node dissection is performed, particularly an axillary lymph node dissection where they remove many lymph nodes, and less so for a smaller procedure called a sentinel node biopsy. Radiotherapy to the armpit makes it worse. Seromas or complications or infections after breast cancer surgery. Being overweight can make it worse. Immobility, and as mentioned before, the taxanes. So how do you find lymphedema? How do we look out for it? So in the past, it was really one of those things you'd see the doctor and they'd see a swollen arm and say, well, that's the price you've got to pay for breast cancer treatment. And, you know, go away. There's not much we can do about it. Patients would feel heaviness, aches or pains, tightness. If you turn your ring, or you might have a wedding ring or another ring on your finger, if it's starting to get tighter. Swelling can be transient after surgery, so that's important to know that it can go away. And pitting edema is when you get your thumb and you press into your forearm or the back of your hand or near your elbow, and it indents. It's a bit like when you fly, for example, and the pressures change and your feet swell up a bit. Your socks might be cutting into your into your ankle, or you may press into the ankle and see some indentation. That's what's called pitting edema. And I'll talk a little bit about that later. What about risk minimisation? What can I do or can't do? Now, usually affected arm, I always recommend, look, use your arm normally for your daily activities. Don't wrap yourself up in cotton wool. Become in tune with your body and look for those symptoms that I mentioned. Maintain a healthy weight with regular exercise. Keep the arm moisturised and your chest wall with some standard moisturiser. In fact, moisturise the back of your hand and push the moisturiser up towards the armpit in an upward direction. And be very careful with your skin and nail hygiene and avoid cutting into the cuticle, and be careful of introducing infection because lymphodematous arm is more prone to infection. It becomes drier. That's why we need to moisturise it. And little cracks in the skin can introduce infection and what's called cellulitis, and that can be quite dangerous. Now, regular exercise, including resistive training exercise, does help the circulation, help those muscles, push the lymphatic fluid along, as well as massage of your arm. Swimming, aquarobics, gym program, weights are all helpful. And there's various information, and I'll mention some of that later in the US context, but this Breast Cancer Network Australia does have a lot of information as well on lymphedema, as well as the Alert Lymphedema program. So how do we measure for lymphedema? Now, in the past, we just used to, I remember when I was a boy in my training, my professor used to get me to, every patient I'd see, he'd ask me to measure 15 centimetres or 10 centimetres below the elbow and 10 centimetres above, and we'd take measurements and we'd do research and see how common it was to have a swollen arm. And a swollen lymphodematous arm was one that measured 2 centimetres different in girth between the affected side and the unaffected side. So it's pretty crude, and the patient would say, what do I do about it? And I'd say, I don't know. We never had enough resources in the hospital for lymphedema. And then slowly, when I established the Breast Cancer Institute and we started the fundraise, we injected a lot of funds into the tiny physiotherapy department, and then set up lymphedema therapists and training. And we started early detection of lymphedema very early on, probably 15, 20 years ago. Now, the problem with the tape measure is this slide's a little bit complicated, but first of all, when you look at an MRI scan of an arm, this is the unaffected arm, this is the affected arm. This is the muscle in the middle. I'm not sure, Sherry, if you can see my mouse. Great. So essentially that's the muscle, and around here is the skin and the fat. And what you see here in the affected side, in the lymphodematous arm, you can see the muscles still. In fact, the muscle's a little bit bigger than the other side. And I might just mention that that's because people are lifting a heavier arm. So it's often the muscle increases in bulk. Okay. This white part down here is in fact the fluid, and you can see the fluid is really deep. The skin here is thickened. So here I am putting my tape measure around. Now, what am I measuring? So if you increase these three scenarios, I get the same 2 centimetre difference. In this first scenario, the muscles and the tissues are larger, and this could happen because of bodybuilding, etc. In this scenario, maybe that the patient's putting on weight, or chemotherapy and hormone therapy has made them increase in weight. The fat goes up, and that still leads to an increase in my tape measure measurement. But it's this situation where we're trying to find that where you get this increase in ECF, which is extracellular fluid, that's that lymphatic fluid, which goes into the tissues. Now, the way I like to describe it is when someone has an axillary dissection, it's like having a river where you put a whole lot of rocks in the way. And that river banks up a bit, it gets wider, and eventually the water goes out the sides into the surrounding paddocks. And those paddocks can become soggy, and that, in a slow running river can be dirtier. The fluid you may not see through it, and therefore it's more prone to infection because you're not clearing it. In a fast flowing river, you don't have those rocks in the way. The fluid's running, and I'll show you how lymphatic fluid moves normally in a minute. It's cleaner and less prone to infection. So I guess what I'm trying to say is this old-fashioned technique of relying on the patient and then using a tape measure is probably a waste of time, but better than nothing. So what are the new methods for assessment of lymphedema? So these are, this top one in the middle is the MRI. We've done a lot of research on this. This is a good old-fashioned tape measure. This is your thumb. You can press into your arm for 60 seconds and see if it pits. And that's a good, simple test. And then it's fluid, but we've picked it up probably too late. This is a lymphatic mapping technique, not generally available, called ICG. And I'll show you what we're doing at Macquarie University in a minute. And this is a technique called a pyrometer. Professor Alphonse Taguien at the Mass General uses this a lot, has done some excellent research on mapping increases in arm volume with time and correlating that with different extensive surgery. This is Professor Hiru Swami, who I attracted from the MD Anderson Hospital in Texas, and he did his fellowship in lymphatic work in originally Japanese in Melbourne, and then came back to Australia, and he's really helped us accelerate a lymphatic program using this IC green indocyanine green injection. We use this thing here, which freezes the skin. We then put a little injection just under the skin of this ICG. We turn the lights off, and we've got special infrared cameras that can, and he does these beautiful diagrams and photographs of seeing what actually happens in an individualized patient. So too much of lymphatic research is very broad and not personalized. And like Ben mentioned, our previous speaker, about precision medicine, we can do more precision medicine and precision tailoring of treatment for patients who've had axillary clearances or breast cancer. So what happens to the river after you put a whole lot of rocks there after an axillary dissection? We know that's the skin. We've got these lymphatic capillaries, an amazing network. They've got little pre-collectors, and then they become into superficial collecting vessels. And it's these ones that we can see with the infrared. We can't see these deep ones which surround bone and nerves. And this is one of our patients. Actually, to be honest, it's probably one of our staff members, and where we injected the dye, and you can see we put a little bit in the wrist as well, and very quickly you can see how quickly the fluid flows right up into the armpit, and that's really like a fast-flowing river. That's what most of us like in a normal arm, or if you don't have lymphedema. It just goes straight up the arm. Now, what happens when you get some backlog and the river starts filling? You start getting all these water tributaries trying to connect with each other because they can't get through. And we know that's what happens with water, and that's what happens with lymphatic fluid as well. And you can see it's trying to connect, joining up with other capillaries, going backwards, heading up around the skin in this red arrow here. And this is called dermal backflow. And we know then we've got a problem, and we've got the beginning of lymphedema, but probably in an earlier stage. And this is what happens in advanced lymphedema when you've got a large, heavy arm. Therapy is not working very well. You may need bandaging and garments, and I'll talk about that. And here, everything's broken, and all you've got is the fluid sort of going almost around in the grass around the river, and then getting back into the river, trying to get back into the river. And that's quite a serious situation. Now, there's a study we did, which I found fascinating, at least. That is that not to totally despair, because even if you throw some rocks in the river, water can still get through. And it's interesting that 75% of patients after an axillary dissection, fluid still got through the armpit, and that's good news. Another 40% went around the back, that's called the clavicular pathway, or there's a vein called the cephalic vein, which goes around the back. And this area here in the low neck is often treated with radiation therapy. And as mentioned earlier, I'm a radiation doctor. So we sometimes treat that area, and what we might be doing for this particular group of patients is blocking the last remaining channel draining the arm. So these days, again, with personalised medicine, with giving patients chemotherapy up front, and perhaps many of them going into remission, some doctors, including myself, are beginning to de-escalate our treatment and come off this neck area and treat more the breast area and less of these glands. Now, sorry I don't have a male variant. As you know, most of the research happens in women, but certainly in our lymphedema program, we see a lot of men with melanoma who've had arm surgery and skin cancers, even trauma, motorbike accidents. There's a whole lot of reasons. Varicose veins can sometimes cause, varicose vein surgery can sometimes cause lymphedema. In about 5%, 6% of cases, the fluid tracks to the other armpit, and sometimes around to the back area as well. And that's important because some lymphatic therapists spend all this time, you might have an hour appointment with them, to spend all this time trying to move fluid down to the groin area. In the classical treatment teaching, therapists would push fluid around, push it to the groin, but we found that none of our patients actually drain to the groin. Very few, in fact. We found the odd patient who has severe breast edema go to the groin. So does early detection of lymphedema help? The short answer is yes. This is what is known as bioimpedance, and we've been using this for 20 years. It was an Australian company, and it's now US-based. We initially used little ECG leads that we put on the patient's arm and the other side. It took forever to do, and we used to use a threshold of 10. As soon as it went above 10 LDEX units, we started massage and put the patients in a sleeve. And in this particular patient, we only saw an increase in GIRF at 24 months. The patient found it here a few months earlier, but we picked it up with the LDEX 8 months earlier. Now, that's when we used to use 10. These days, we use 6.5 from baseline. We get a baseline measure. We then measure 6.5 above, and that we would have picked it up here, which would have been 22 months earlier. So that's the advantage of LDEX. You don't have to get your poor junior doctors getting the tape measure out or not measuring it at all, but it can be done very quickly in about 7 to 10 seconds, in fact. You do need to take your shoes and socks off. So what we do these days is we do prospective surveillance to detect stage 0 lymphedema. That's called subclinical lymphedema. It's not visible. It's a bit like mammography in women. We don't want to find a big cancer. We want to pick it up before you can actually feel it. This is called bioimpedance. Now, if you don't have bioimpedance, tape measure is still good. It's just more time consuming, a little bit less accurate. And but I think you should push your departments to introduce bioimpedance. And once you pick it up early, and even before you pick it up early, you need to educate the patient about skin care, the advantage of exercise, and early intervention with a stocking, a garment, I should say, if there's any changes, and it's often reversible. The really exciting thing about this company, and I'm a shareholder of this company. I bought shares. I don't buy shares. So I don't understand them. Every time I buy shares, I lose money. So this is the only shares I bought, and they have gone down in price, and I've lost money again. I put the jinx on whenever I buy some shares. But the reason I bought them is I'm just really excited about this product because for me and my patients, it means I can quickly assess not only lymphedema, but also their body composition. I know how much muscle mass they've got if they've lost muscle with chemotherapy. They're presenting some data on bone mineral content at San Antonio Breast Conference this year. They're beginning to use it in heart failure rather than a doctor using a stethoscope or again, using the pitting test in the ankles or trying to figure out, they're working out the fluid balance with these devices and renal failure. And we can then look at nutrition management. So that's the only reason I bought shares, because I've been doing a lot of research with this group, and I just really like it. And I think one day, this is the future of healthcare. It's precision medicine. It's not about just saying to somebody, do some exercise, but it's saying to somebody, look, you've reduced your fat-free mass, you've built up your muscles, and by the way, you're a bit dehydrated. I know in some centres, I think the centre in Kansas that I heard about, there's got 14 of these all around their hospital. And if patients come in and have chemotherapy, they might find out, or they might be having radiotherapy for head and neck cancer, they might find out that they're severely dehydrated. They might admit them and give them some fluids rather than waiting for them to come into the emergency room. And this is a trial that our group was involved in at Macquarie University, and we've got Professor Sheila Reidner, who's an amazing investigator in lymphedema, again from the Vanderbilt University. And we enrolled 1,200 patients in 10 centres, and ours is the biggest centre with 400 patients. And we basically randomised patients to tape measure or LDEX, and we found, interestingly, I just assumed that the LDEX would trigger subclinical lymphedema more frequently because it's more sensitive. But in fact, counterintuitively, it was the people having tape measure, probably because of what I said before, where are we measuring fat? Are we measuring muscle? There was a higher incidence of triggers, suggesting a higher false positive, so nearly 30% versus 20%. And these patients that we monitored and had access to monitoring, the progression to chronic lymphedema requiring a garment, which, as I said, is quite distressing, was 20% versus 8% in the LDEX group. So I think there is some advantage, at least in the 3-year data, for finding it early when it's just a tiny amount of fluid and perhaps a break in some of those lymphatic vessels, which can be reversible by putting on a garment, something as simple as a garment. Now, this is the company marketing, and they produce these little sheets, but I like it because it's simple for my patients. You test, if it triggers you, then treat. So you test with an LDEX, and these days we do it on a SOZO. So for my patients who have axillary clearance and radiotherapy, I do this every 3 months. And some places charge for this. In America, in the USA, there's reimbursements. We don't have reimbursements in Australia. If it's less severe, then we would do a bit more, less frequent. If it triggers 6.5 above baseline, then we can treat with an over-the-counter compression garment, 4 weeks, some self-directed massage, wear it for 12 hours a day. And a lot of these patients then go back to normal. So I'm just going to pause for a second and just have a drink of water. So can lymphedema be treated conservatively? I'm not a therapist, but I work with a lot of good therapists, and these are the sort of toolkit of what can be done. Obviously, yourself, we mentioned skincare, water-based sports, walking, exercise. You can get garments, bandaging in severe cases to try and get the fluid down and then put a garment in. And you can get these compression sleeves that are compression pumps, and you can hire them or buy them and do that compression at night, watching TV with your feet up on a chair and do it for an hour a day. Can lymphedema be treated surgically? We started a large surgical program at Macquarie University, and we have patients coming to us from all over the country. And this is our multidisciplinary team, and that I set up a bunch of committed therapists. This is Dr. Helen Mackey on the right, who spent her whole career as a rehab specialist. The problem with lymphedema is nobody has ownership of it. You might have a dermatologist doing it in one place, a cardiologist in another, a rehab specialist, sometimes oncologists. And but we've had a mixture of therapists, radiologists, plastic surgeons, and this is Louise Colmeyer here in the pink, who's now the director of the Alert and a great colleague and friend. Since I left, they've got a new building with a different approach. I must say I don't like this as much when you're looking at people's backs. But so be it, it seems to work still. And I was really excited. We've got a lot of connections in the USA. When we had our joint multidisciplinary meeting with the Harvard Beth Israel, and Drew Singles is doing some amazing work at the Beth Israel Hospital. But that was a really great experience, bringing together our teams, and it's happened again, and learning from each other. This was our first liposuction patient. We've done this for a lot of men as well, particularly in the legs. But this patient for 10 years couldn't wear a coat or wear long sleeves, and she had liposuction, and her arm went back to normal. You still have to wear a compression garment, and we are experimenting as groups in the USA on joining these lymphatic vessels to using microsurgery, amazing work. You operate with these very strong microscopes and very fine threads. You join a functioning lymphatic or a blocked lymphatic to a vein. We do lymph node transfers for selected patients, where you can remove some lymph nodes from the opposite neck and move it into the armpit. And sometimes we do reconstructions and move lymph glands in at the same time. So that's a background. Now, what about for you as individuals? There's a lot of myths out there. What's fact, what's fiction? It's confusing. It's confusing for us as doctors. Can you fly? I've heard of patients who've stopped flying after breast cancer surgery, and that's a myth. Most studies do not show that flying impacts on lymphedema, but certainly there was one study where they had some dragon boat rowers, including men, who had a conference in Brisbane, Australia, and they did bioimpedance in Canada, and then they did it when they landed in Australia. And there was, I think, one patient who went from negative to positive, and that particular patient had an axillary clearance, but there was no patients if you had a sentinel node biopsy. This is very old data where patients self-reported that it got worse after flying, and certainly I've seen it. It doesn't mean you shouldn't fly, but it does mean that if you're at higher risk, for example, you're overweight, you've had an axillary dissection, you've had radiotherapy, I would see a lymphedema therapist and get a compression sleeve before you fly. You might even want to have a window seat and put your arm up even on a pillow, drink lots of fluids on the plane, not too much alcohol, and move around as well to prevent venous thrombosis. There's no, we do say avoid injections into the affected side, and that is true. But because if you've got a healthy other side, but many of our patients get a lot of vein damage from chemotherapy. So if you have a blood collector who's failing, can't find that vein, it's very frustrating, it's distressing for you and them, then give them permission to use the other side, but obviously make sure they wipe the area down with betadine, alcohol, and even if you scratch yourself in the garden or you see a bit of reddening, wash down the skin and put on an antibiotic cream. If it turns out to be a full-blown infection, you really need to get onto some antibiotics very, very quickly. It can be very dangerous. I wrote a book recently on vaccinations before and after cancer treatments. Includes the pneumovax, shingles vaccine, COVID vaccine, and so on. And because we don't do it too well in medicine in terms of recommending vaccinations. Some centres in the USA are doing it really well. They have vaccination clinics. And I'd be interested to know if any of your listeners today have got advice about vaccinations. But the really important thing is don't have vaccinations in the side that you've had surgery. A couple of my patients with the COVID vaccine had pretty severe reactions, and they were never asked, which side to have it done or so that's a message to take away. Avoid blood pressure measurements. Again, if you've got severe lymphedema, it's very hard to put a blood pressure cuff on and obviously use the other side. But if you've had surgery on both sides, do the blood pressure on the least affected side. It's hard to do blood pressure measurements on the leg, but it can be done. And we know we use pneumatic pumps for lymphedema, that compression pump I showed you earlier, and pressure improves lymphatic flow. So I'm not sure where this whole science of avoided blood pressure measurement actually came from. Because compression, in fact, I wouldn't go overboard on the compression. I'd probably use a manual pump rather than one of those automatic pumps because they they go to very high pressures. I'd probably just use the old-fashioned pump, blood pressure kit. Some doctors try diuretics like Lasix and Moduretic, and really doesn't work because those drugs affect the fluid in the vascular, the veins and the arteries, and not this fluid in the surrounding tissue. It can make you dehydrated, change your potassium levels. Do I need to wrap myself in cotton wool? Do not exercise with a limb of lymphedema. That's also a fallacy. It's false. It's good to build up your muscles. Exercise improves lymphatic flow. If you do extreme exercises, you can wear a garment during exercise, particularly if you have lymphedema, because obviously you're getting higher lymphatic flow. So if you do have lymphedema, or even if you're high risk, maybe wear a garment. Some of my patients wear a black garment and it sort of blends in with their gym gear. If you're overweight, have a high BMI, just bear that in mind. It's a risk factor for heart disease as well. And you need to and I know it's hard, particularly after going through cancer treatment, but you need to look at diet as well. Now, in one study of weightlifting, lymphedema was less, not more. Extreme temperature may worsen lymphedema. There's one study that found sauna use increased the risk of lymphedema. There's not a lot of data out there, but I think be sensible, be very careful. Don't, use sunscreen when you're out in the sun. Wear a rash shirt. A lot of my male patients wear one of those, we call them rash shirts in Australia, which can protect you, but also hide your scar if you're self-conscious, which some of my patients are, of course, and avoid sunburn, which can introduce infection, and avoid hot baths, etc. But there was one study in lower leg lymphedema where they put 12 poor patients in hot water, and in fact, it showed a reduction in leg volume. So it's hard to know, but I think be sensible, read, learn. You can still have baths, but don't make them too hot. Don't operate on lymphedema. We've operated now on, I think, over 150 patients. There's lots of studies. Now, people are going to get skin cancer, they're going to get carpal tunnel syndrome, which is more common after hormone treatments. And it's important to have those conditions done properly, not in your sort of low-cost centre where perhaps, if you're concerned about hygiene, you may want to do it as a day-only case, and make sure it's done in a minor operation theatre. And we know that even patients who have reconstruction have less lymphedema. So you need to look after your general health, skin conditions and other things, and don't get too frightened if you need to have an operation. But if it gets red, I'd probably look at some prophylactic antibiotics. If it gets red after the operation, make sure you're on antibiotics. So in summary, most of these things are fiction. Take care with flying, particularly long distances. In Australia, we fly, to East Coast of the USA or to London. It takes us like 22 hours. And so they're the sort of patients I worry about who go on long trips. If they're just, going up 1 hour up the road to Brisbane or Melbourne, I sometimes say, look, particularly if they're low risk, take the chance without wearing a garment or get an over-the-counter garment. But if you're high risk, wear a garment. Now, to be honest, I don't know a lot about the American therapy scene, but what I've read, certainly the Lymphatic Education and Research Network is a great source of information. They, in fact, accredited our centre. It's the only centre accredited in Australia. And there is certainly a presentation now on how to find qualified lymphedema therapists. And these are some of the organisations that I'm aware of that I've found through the Lymphatic Network and so on, that may give you some connections there. But word of mouth is often very important. Talk to your doctor, but in many parts of the USA and around the world, there's all sorts of issues with lymphedema, and this was the case in Australia 20 or 30 years ago. It's a lot better in Australia now, but there's cost issues, poor reimbursements, having abbreviated care rather than proper bandaging techniques, no monitoring, no follow-up, no team, no ownership, and lack of a self-care toolbox. So it's really important, and I am writing a book on this at the moment called Lymphedema and Cancer Taking Control, where hopefully I'll be able to document this in plain English and see what you can do for yourself. Two or three more slides. Regular screening is important. Skin care is important. Avoid injections on the treated side where possible, but it's not an absolute contraindication. I always give my patients some antibiotics when they travel, maybe some Keflex if they're not allergic to it, because the last thing you want is getting a red chest wall or red arm or having cellulitis when you're traveling, particularly if you've had one episode. take some with you rather than trying to access healthcare when you're overseas or in another state. And consider precautions for air travel according to level of risk. Regulate aerobic and graded resistance training exercises. See a certified lymphedema therapist. I'm not sure about the ICGs in the USA. I think certainly Harvard's doing it and more places are doing it. But there are other ways, even using types of radiation to look at lymphatic mapping, the sort of radiation we use for sentinel node biopsy. Consider lymphatic surgery for eligible cases, but it's not a total solution. Very liposuction works well, but I'm not totally convinced about lymph node transfers and lymphatic surgery as yet, but we're still doing the research on it. And see a therapist if you're high risk. Be
still the
alert
same guy.
and not alarmed. And thank you very much.
Thank you, John. Great presentation. I know, Marlon, do you struggle with lymphedema a bit? You're going to have to unmute. There you go. Oh, you're remuted. There
we go. Yeah, and I wear a sleeve. This is a dark one today.
That's a good one, yeah.
Yeah.
I wear it's a custom measured for just for me.
How much did that cost you, by the way?
I get mine through the VA, so I don't pay a penny for them, which is rare.
Yes.
We do, well, we don't partner with, but we do have an organization that we do get sleeves from who give us a discount. We've actually had some that we've donated, some of our men in Australia or people that are having a harder time getting them, we will send them over for lymphedivas, they're called.
Yes.
And for the men, they actually don't publicize this, but they do have the ones for the men, and it's called Lymphedudes.
Yes.
It is on our website.
It's on the website, yeah.
Under
Great.
products, on tools and resources.
Yeah, they've got some of them are beautiful. I mean, they're works of art.
Yes,
it's like getting a really elaborate tattoo.
Yes.
Yes, I've seen some of those. They're amazing.
Yeah. I know we do have some men. He's actually David Dudak. He's struggling a lot with lymphedema, and I know that was one of the subjects that we were requested to present on. So thank you for that. I'm pretty sure he goes to MD Anderson, and I think they've hooked him up with someone that gives him a lot of massage treatment and the drainage. Yeah. So I know they're available. We do have some information on it. Yeah. Howard, do you have any questions for John? You got to unmute. Sorry.
They probably all want an early mark because you've
Yeah.
had such a long day.
I know he's talking. Howard, can you unmute yourself? We can't hear you. I'm sorry. There you go.
Let me try. Can you hear me now?
Yes.
Okay. Yeah, I wear a garment called Juxtafit on my legs because my legs actually are the worst part on my body. And Juxtafit makes a really good adjustable garment. So,
okay.
Yeah.
All right. And the what was the other one? Madeira, I think, is another company.
Medina.
Medina, yes, that's
yeah.
it. We've worked with them, and the same gentleman that I said we've gotten actually gauntlets for him because he's in a wheelchair, and he actually has to wear not a vest but a full upper
torso.
Torso compression. Yep.
And then you have the compression stuff you can get too, FlexiFit, and there's several of them that are really good.
Have you ever had any infections, Marlon?
Yes, I have. When I was first, actually, I was going through my chemotherapy treatments, I had 3 times I had to make a run to the emergency room because my arm would swell up so fast
Mm,
that they couldn't control it. And I've learned at that point, you have to keep impeccably clean arms
yeah,
because anything can pick it up. And especially if you're around infections and stuff, around sick people or stuff. When I went to the hospital, they didn't even let me stop in the waiting room.
yes. It can be quite
Once they
dangerous.
found out what was going on, they put me in a room immediately.
Mm.
Mm.
I was at a lymphedema conference once, and there was a very passionate speaker who recommended a weekly brown bath for all of us, and that's chlorhexidine or betadine in the shower, and just put it all over yourself for about a
Oh,
minute,
cleansing.
and then just let it sit there, and then wash it off with your normal soap. As a way of getting rid of the trillions of bugs on our skin,
Yeah.
and reduce. So that I when patients get recurrent infections, I tell them about that, and
Mhm.
around the nail beds and
Yep.
just
And then
all over.
using moisturizer every day.
Absolutely, very important.
Mm. Michael, any questions? Did you have that? Did you deal with lymphedema at all?
No, I didn't.
You didn't.
No.
Yeah.
Did you have an axillary clearance, Michael, or a sentinel node biopsy?
Sentinel and non-sentinel node biopsy.
Okay. Yeah, and that's the advantage of you get a reduced risk of lymphedema, and
Yeah.
for many men that wasn't being done for many years, and hence
Mm.
There
Interesting.
is a clinical drug trial just starting. Well, it's been going for a little while out of Stanford University, and it's for an inflammation drug, which has been used for other things very successfully. And they're now testing it on people with lymphedema in one extremity only. I'm
Oh.
kind of trying to get in the running for it, but it's very strict. So I don't know if I'm going to make it or not, but I'm hoping to.
yeah, I know Stanley Roxon quite well.
Yes, that's who's doing it.
Sure, and we did a trial with him on a similar drug back in 2017. Unfortunately, it wasn't successful, but he's quite passionate about, because there is a lot of inflammation that happens when that fluid leaks into the surrounding
Yes.
tissue, and then that stimulates the fat stem cells to then grow and become quite fatty. That's why we do liposuction, because eventually the arm is not fluid. It's actually, and compression doesn't work. It becomes very fatty. And
Yes.
if we can stop it before that phase, perhaps early detection. And I think his first trial was on patients with, big swollen arms. My view is it needs to be, these anti-inflammatories need to be done a lot earlier in the natural history.
I think that's what they're doing now is
Yeah.
taking smaller ones.
Yeah.
Yeah. Instead of waiting for it to build up and happen.
Yeah.
Exactly.
Interesting. I wonder, I don't know how it works by you, but I think liposuction here in the United States would be considered something that wouldn't be covered by insurance because it would be
Yeah.
cosmetic.
Yeah.
Is that something by you that is covered when it's deemed necessary for a patient with lymphedema?
We've got these standard letters that we write to their health insurance and say, look, this is a consequence. It's not cosmetic surgery, it's because people are getting recurrent infections, and infection rate goes down after liposuction, virtually zero, and affecting quality of life. They can't lift or they can't exercise.
Right.
So we sort of run that argument for a while, and then try to pressure the insurance companies to support that individual patient. And sometimes, most of the times, the insurance companies come around to it.
Okay. Well, that's good to know. Yeah, I think some of their rule books are a little antiquated.
Yeah.
Definitely.
Exactly.
Well, any more questions, comments?
One other
Anybody?
real quick comment, it's kind of, or coincidental that just within an hour ago, I got a phone call from my lymphedema physical therapist wanting to know if I want to take part in a sleeve fitting event at the VA next month, where they're going to have people come in, they're going to do custom measurements and provide garments, and they want different people for different things. And I
Wow.
just signed up for it, and I was like, whoa.
That's nice.
That's
That's nice. Yeah, that they offer
Yeah.
that.
coincidental. Yeah.
I think
Yeah.
Rebecca has her hand up with a question.
Oh, Rebecca, I'm so sorry.
It's okay. I was just waiting. I have a question. I'm sort of confused. How long does one or, well, my husband have to worry about getting lymphedema after his mastectomy? Because we were under the impression that it was just something while he was recovering from surgery. No?
It can
Look,
be up to a year or more later still.
It's a
Oh,
really good question. So you need to look at the risk level for your husband. Has he had a lot of lymph nodes removed, or is it just a sentinel node? Is he having radiotherapy into the neck area or into the glands? And probably look, to be honest, most of it occurs we pick it up in the first 2 years, but the risk is theoretically lifelong. You need to be careful with, occasionally can happen later, but certainly the first 5 years, most of the cases appear in the first 5 years, and most within the first 18 months, particularly in the severe cases. There's some evidence from Alphonse Tagian at the Mass General that if you just had a sentinel node and a radiotherapy may just take a bit longer, the radiotherapy effect takes a bit longer and might be slightly higher between years 2 and 5.
okay. I know he had
but
the centennial node. He had 28 lymph nodes removed.
Yeah.
That's a
Yeah.
lot.
It's
Yeah.
a lot. Okay.
Yeah, so I think, is he currently having chemotherapy, or has he finished his treatment?
He's having chemotherapy tomorrow's his last treatment, and then he'll start radiation. We don't know anything about radiation yet. Our doctor is very much into one day at a time, he doesn't want to overwhelm us, but that's kind of scary at the same time, He
Yeah.
had he's going to have a total of 4 treatments of chemotherapy, but we don't know anything about radiation yet, how many or what that's going to look like.
Yeah, I mean, my book, Male Breast Cancer Taking Control.
That one we have. You're
Uh,
blurred. There a little bit further.
Certainly breaks it down into chapters. You can download it from iTunes or Amazon. I think Kindle, information's power, and particularly for support people like you, Rebecca, it's you do feel helpless at times, and there's a lot of pressure on the support people. And I think somebody mentioned that earlier, and I think having that information is important. Yeah, your husband is at risk for lymphedema. Some centres are even doing prophylactic compression garments in that situation. And I'd certainly try and see if you can get him to see a lymphedema therapist now for some measurements, some advice on skin care, if they can do
Have a base.
Yeah, and then at least have a connection there, because the risk is pretty high, to be honest, probably 1 in 4.
Yeah.
Hopefully you won't get it, but
Okay, thank you so much. I appreciate it.
And if anything does come of it, have them get involved with a support group. I learned so much I'm in 2 different support groups for lymphedema. And I learned more through that than anything else.
yeah, it's so true.
Yeah.